Well, good morning and welcome to the Minneapolis Heart Institute Ring Rounds. Today, May 1st. We were really delighted to have a great friend and colleague, Dr. Mouaz Al-Mallah. And before that, I would like to also thank the exhibits by Novartis and Pfizer. Dr. Al-Mallah received his medical degree from American University of Beirut in Lebanon and completed his training at Henry Ford Hospital, Wayne State, and then at the Brigham and Women's Hospital. He's currently now the president of American Society of Nuclear Cardiology, as well as the director of the cardiovascular PET program at the Houston Methodist Baker. Before getting to that position, obviously there's a big journey that he starts obviously from Lebanon and then had moved up on the ranks in serving in many capacities, several other places as well, especially at the King Faisal in Saudi Arabia, where he set up a PET program, not only PET, but also many disciplinary other cardiac MRI and cardiac CT to a huge volume and bringing the visibility of that program. He is a prolific researcher. He has done more than 400 publications in cardiac PET, cardiac MRI, and he has won also many awards for teaching skills. So truly a triple threat. And most importantly, he is one that inspired me to pursue cardiac imaging. So we overlapped back at Henry Ford Hospital, and because of this idea that we could use imaging to direct patient care, that inspired me to pursue that same pathway. So really, truly a pleasure to have you here with us, Mouaz, talking about the disease that is really an enigma, cardiac sarcoidosis, which truly blends more than just one imaging and the clinical picture and scenario. So welcome to Minneapolis, Mouaz. Thank you.
All right. Well, good morning, everyone, and thanks, Joao, for the kind introduction. And it has been really a pleasure to see you also rise through the ranks. And I've known Joao now for 20 plus years when he came in as an intern and have gone through a lot of positions and research and clinical skills, and happy to see your progress. All right, so Joao asked me to talk about cardiac sarcoidosis, and obviously I'm preaching to the cure because you guys see a lot of this and you have a lot of imaging, advanced imaging that uses. So I'm gonna try to shed some light on this topic, which actually started my interest, and believe it or not, my first grant from American Heart Association was about cardiac sarcoidosis. And this is a disease was so prevalent in Detroit when we were there, and it's very common among African American population, mostly pulmonary sarcoid, and it is a disease that's tough to diagnose, tough to manage. It requires a multidisciplinary approach, and then cardiac imaging requires multimodality. So these are my disclosures. They're not related to this topic. So let's start with the case. And Joao might remember this case because this is actually from 20 years ago. And I was a CCU fellow. He was a resident with me. And I was like preparing for this talk, and it was a Friday afternoon, and we were called, come down to the emergency room. There is a 33-year-old worker actually around 1 or 2 p.m. on a Friday who just passed out, no past medical history. EMS called, and he was in ventricular tachycardia. So they came in and shocked him and got him to the CCU. We immediately, no family history, no prior diseases that's been known. We were called to do an echo immediately in the emergency room, and his echocardiogram was 35%, multiple regional wall motion abnormalities. So we took him like Friday evening to the cath lab. Obviously, no coronaries, minimal troponin elevation. Stabilized overnight, extubated in the weekend, and on Monday we took him down to do a cardiac MRI. So let's start. This is his chest X-ray on presentation, and you can see some hilar fullness, and it was read as may reflected enopathy. And this is his cardiac MRI, and this is 20 years old, and you can see how far MRI has gone, but cine images were even good at that time. And you can appreciate the low ejection fraction, the regional wall motion abnormalities that you see here. And when we look even at the lower ejection fraction, it was like closer to 40, and you can see multiple areas of regional wall motion abnormalities. We did do edema imaging, and there was some concern that this area, the anterior anteroseptal, is brighter than the inferolateral wall. And this is the kind of home image, which is the typical image that you might see in this kind of disease, which is epicardial late gadolinium enhancement that we see here. It's very bright, involving the RV, and it's all the way from the base to the apex. You can even see the RV there. And this is clearly a patient in this kind of clinical setting. We know that this patient is likely sarcoid, and eventually he had bronchoscopy and biopsy of some of these lymph nodes, which showed these non-caseating granulomas. Sometimes, so I gave you more of a very classical presentation. I mean, it cannot get any better. This patient didn't have sarcoid before, was not even known to have sarcoid. But there are some, it's not always as easy and as straightforward to make the diagnosis. And that's why it's very difficult to make these diagnoses many times. So let's talk a little bit about the disease and see what tools we have now in our box 20 years later from the first case that I've showed you here. So the prevalence is very different among races between African Americans or black versus white. And it's estimated to be around 200K cases in the United States right now. In Europe, it's Scandinavians and Japanese have the highest prevalence. And I understand that if we look at, last night I went online and I put where do Americans of Scandinavian origin live, and you can see what it is. So it's like no doubt that you guys are at the top of it. And in fact, there are 1.58 million people of Scandinavian origin just from Minnesota. So it is the highest population in the Europe that have this origin, and they are just around you here. So if I'm to, probably you are more suspecting this disease more often than anyone else. So this is like, that's why I thought that this is an area where among Caucasian, you're probably gonna see more. And in Caucasian, from our experience in Detroit, Caucasian or white patients tend to have more extrapulmonary sarcoid, and African American have more of the pulmonary sarcoid kind of. So we've scanned many patients there, and they would have like end-stage pulmonary, but then you look at other organs, brain, eye, heart, and there were like very little, if any. And then you look at this patient had no non-cardiac disease known even, and their first presentation was cardiac involvement. So the hallmark of the diseases are these non-caseating granuloma. The pathophysiology is not very well known, and there are a lot of theories about it. I'm not gonna go there. Let's keep it clinical. And the disease is also very patchy. So this is an autopsy of a patient, and you can see there are some areas that are involved, some areas that are not involved. And that's why it is very difficult to make that kind of diagnosis. And for those of you who make myocardial biopsy, obviously it's not going to be easy to do that. Even with the advances of biopsies that we have where we go EKG guided or MRI guided or even PET guided, it's not easy to go and figure out exactly where you want to do the biopsy. And that's why there have been a lot of push to come up with some clinical criteria for that. And there are many of them. Again, I'm not going to go this route. There's a Japanese criteria, and then there's a revised Japanese criteria. In the US, we're mostly using the heart rhythm expert consensus, which I'm going to take 1 minute to say. For cardiac sarcoid, the criteria says that you need to have a histologic diagnosis of extracardiac sarcoid, and then you need one of these. So one of these are late gadolinium enhancement or positive gallium scan or positive FTG PET or unexplained VT. So obviously someone might argue like unexplained VT and extracardiac sarcoid doesn't always add up, and that has been some criticism of this criteria. And that's why it may require some additional information or maybe additional revisions in the future to kind of see how do we put our workup algorithm. But it kind of raises your suspicion if you have somebody with extracardiac sarcoid, but I wouldn't say that this is definite, because even if you have extracardiac sarcoid and the VT, it may be multiple other causes. Okay, so let's start, like, what's in our toolbox. Obviously, cardiac MRI, like we did 20 years ago, still remains at the forefront for that. And cardiac MRI is a great tool, really, to help us differentiate ischemic from non-ischemic cardiomyopathies, but also in the non-ischemic cardiomyopathy, help us tease out what type of non-ischemic cardiomyopathy we have. For the trainees in the audience, we primarily are looking for late gadolinium enhancement, which is areas of expanded extracellular volume. And what we are trying to look for, it's not the presence or absence of late gadolinium enhancement, but rather the pattern that will help us guide. So when we talk about pattern, obviously there will be a lot of overlap. So again, you're not going to be able to say this is typical cardiac sarcoid, or this is like, the uptake itself may not be pathognomonic. There are some patterns that are more likely to guide you one way or the other, but there is also a lot of overlap. That's why when you order cardiac MRI, sometimes you have the differential includes XYZ, and that's why you need to narrow it down with others. So if we take a typical cardiac case where you have some areas of regional wall motion abnormality, if you do edema imaging, you might see some edema, and then late gadolinium enhancement that you see it on multiple areas, which does not follow a coronary distribution. And that's why most often these patients will need some sort of coronary assessment to rule out epicardial coronary disease, because sometimes there is an overlap of that. So the hallmark here, you see, for example, a case where there is significant late gadolinium enhancement. If you're lucky enough to do a biopsy at that spot, you might see these non-caseating granulomas like you see here. So what are the patterns that make us more suspicious of cardiac sarcoid that we see here? And the patterns, these have been described many years ago by the Duke group. This is like almost a 14-year-old paper where they described 5 patterns. And obviously, some of them might have just very little late gadolinium enhancement, and some of them may overlap with other diseases. For example, this pattern A is a subendocardial LGE. That may not be differentiated from a patient who have coronary disease, because that's kind of the main one. But the most specific one are similar to the one that I've shown you here, this pattern D, where you have the subepicardial interseptum and the RV. That's kind of very pathognomonic for cardiac sarcoid. And this also patchy uptake, which does not always obviously indicate cardiac sarcoid, but can overlap also with other cardiomyopathies, myocarditic processes, and that's why you may end up like suspecting cardiac sarcoid in these patients. Now, recently here from Minneapolis, but from the university, Shitan Shitoy and his group, they went and reviewed all the literature of those who had actually patients who had autopsies in the literature. And what they found, obviously, now you're talking about the way other end of the spectrum. So we're looking at those who either were transplanted or had autopsies, and we're looking at what types of patterns we see with late gadolinium enhancement. And they describe them as kind of the more common. So you see here, it's epicardial, multifocal, involving the RV. But again, this is at the other end of the spectrum. So we do not want to wait until we get to that point. Would rather probably catch up our patients much earlier. And that's why they went back in their registry, and they have almost 500 patients who have biopsy-proven extracardiac sarcoid or cardiac sarcoid, and then they went back and looked at the MRI patterns. Obviously, the one pattern they have where there was no late gadolinium enhancement. So somebody like what we saw often in Detroit, which is somebody with pulmonary sarcoid but no cardiac involvement. Or sometimes you could have no LGE but abnormal left ventricular ejection fraction from other causes. Could be hypertensive heart disease, other idiopathic dilated cardiomyopathies. So that's kind of also another group there. When you look at the patterns of those who have these then you have two types. One of them is the extensive kind of LGE. And obviously, this is a patient who's also at the other end of the spectrum where they have so much cardiac involvement. And these are the patients at a higher risk of having events. Obviously, if we know from cardiac MRI literature, the more scarring you have, the more late gadolinium you have, the more the patient will have events. Or you might have just a very focal one. Our hope that we can catch these patients, the rare LGE, and hopefully prevent them at least from progressing to become at that stage. Because once they reach that stage, I'm not sure we have so much to offer these patients in terms of therapies that might reverse the course of the disease, unless a lot of it is reversible. So when they looked at the outcomes of these patients, it's no surprise that those who have this pattern are the ones that have the worst outcome. So if I'm going to play the odds, I mean, this is very much correlating with late gadolinium enhancement. So I wouldn't, again, and also when you catch these patients at this stage, it is very common that these patients are going to have adverse events long term. So it's kind of more of a surrogate of the amount of late gadolinium enhancement that you have. Now, what about this case? Why they're not doing this much? Well, recently there have been some data suggest that many of these 1%, 2% kind of late gadolinium enhancement, if you have normal left ventricular function, it may not incur that much higher risk. A lot of it may be related to the therapies that we have. So there have been some data like 20 years ago where even minor scars may have attributed to long-term outcomes. But now we know that with the therapies that we have, it may not be as bad as has been initially described. So that's kind of the first one. So when we're looking at outcomes, you can see that this is a recent meta-analysis that just came out like a couple of weeks ago that looked at the amount of late gadolinium enhancement or the presence or absence of late gadolinium enhancement either in the left ventricle or in biventricular. And what they found is that, no surprise, it's associated with all-cause mortality and ventricular arrhythmias and the composite endpoint. And when you have actually biventricular, you can see that there is almost 43 times chance of having ventricular arrhythmias, like what we saw in our patient. I mean, his presentation was a ventricular arrhythmia. And you can see that even those LGE positive, the annual event rate is almost 15% or closer to 15%. So this is a group that their annual event rate, once you demonstrated LGE, is going to be pretty high. So the question is, what do we do? And what's the mechanism of ventricular arrhythmias in these patients? Some of it may be triggered by the scar itself, or some of it may be triggered by the active inflammation. And this is where we try to understand this a little bit more, whether we can do something about it. Obviously, if it's scar-mediated, this is where our colleagues in electrophysiology are going to try to do some ablations and otherwise. But if it is scar-mediated, unfortunately, if it is inflammation-mediated, maybe we can do some follow-up studies, put some studies. And this is an old paper where there were initial trials to go ahead and try to see if maybe if we have this patient and I can go ahead and give them therapies, would I detect the impact of therapy on MRI? And it was a little bit disappointing, and this has been it depends what the cause of LGE. If the cause of LGE is edema, yeah, you might get some regression of that. But if the cause of LGE is scarring, scarring is not going to go away with immunosuppressive data, and I'll show you this. There's a lot of interest also in mapping. I know Joa has been kind of interested in this, especially for ECV and others. But here we're talking about more of edema imaging and T2 mapping. And this is a couple of cases from a paper like almost 6 years ago that looked at late gadolinium enhancement and looked at edema there. So it kind of whether it will hint you whether this is acute or chronic. So here you have late gadolinium enhancement with edema, so they called it acute. Here you have so much late gadolinium enhancement, but no edema. And then you may say, well, this is chronic and this is more scar. That is more of a qualitative way. Another paper that looked at this, and the reason this is probably not has picked up that much is because there is so much overlap between these. So if you look at all these parameters, like for example, let's take the T2, the difference between the acute versus chronic is 52 to 49. And when you look at the overlap, they're like so much overlap. So there is no number I can tell you is like if it is below this number, then you're going to be calling it acute, and there is no number you're going to call it chronic. And that's why we still rely on other modalities really to try to understand it. Like a case like this, yeah, I'd probably be more concerned, but it's not always this black and white with edema imaging. And usually these patients who have low ejection fraction, they might end up also having slow flow, and you might get slow flow artifact. And this is where we need to call into some other modalities to kind of help us to determine whether this is acute inflammation or chronic scarring. And this is where cardiac PET comes handy in the management algorithm, because now I will be like, once we started with MRI, we found LGE, I want to know if it is acute or chronic. And obviously the clinical story is going to help you, but also MRI PET is the way to go to look for these patients. So here's a patient also who have late gadolinium enhancement, very similar pattern. When we do perfusion imaging, we see a perfusion defect, and then I do FTG imaging, and now I see significant FTG uptake in that area, indicating that there are, with FTG, we're imaging active white blood cells and macrophages. So we know that there are macrophages that are pretty active in that segment. So I'm just gonna cover a little bit. This has been an area of interest for me, looking at FTG PET for cardiac sarcoid. And if you're doing it right, this is what you see. So in a patient without cardiac sarcoid or cardiac inflammation, then you don't get any uptake, and all the FTG stay in the blood pool, and you see there is no uptake in the myocardium. If you look at it, so to get that image, how do we achieve that? And I'm going to emphasize on that, because really the trick with FTG PET is how do you get your patient to be prepared? Otherwise, we will be calling ton of cause a pandemic of cardiac sarcoid. So the main thing is to get them well prepared. And most of us actually have gone from even 1 day before to 2 days before, where we start calling the patient and making sure that they have no carbohydrates and completely lower it down to eating only fat or protein. So we have made a long list of food, and patients continue to surprise us with coming up with something that's not on our list, but we make a long list of what they can eat and what they cannot eat. So we give them that list, and we also tell them everything that goes down your mouth, I want to know what it is. So they write it down, and then we ask them to do a 12-hour of fast. And then we go ahead, when they come to us, we do the perfusion imaging. We give heparin because it increases lipolysis, so it increases actually free fatty acids. So this is what the heart likes, so it doesn't take FTG. And then we give the FTG and image them after. So this is kind of our protocol. But the biggest preparation is the day before. And when they come to us and we find any carbohydrate that they've consumed, we're just not going to do the test. We reschedule them because otherwise it will be poorly interpreted and may cause the risk of misinterpretation. So here's a patient where you see a perfusion defect. So I know there is a scar, but there is no FTG uptake, and all the FTG in the blood pool. I'm pretty happy about it, and this is a negative study. When I go and look at an abnormal study, now I see a perfusion defect there. I see a corresponding FTG uptake. And this is very diagnostic, or like this is kind of the typical pattern that we see with this. We can also look at the RV. You can look also at the basal septum, and you can see the FTG uptake that we get here. Because we're using hybrid imaging for this, we not only see the LV, but we can also see the atrium. And this patient actually had a lot of atrial uptake. So for our EP colleagues, they like that because this is where a lot of these patients may have inappropriate atrial arrhythmias, atrial tachycardias, inappropriate ICD shocks. And this is where it's going to be very helpful to alert them about FTG uptake in the right atrium. And because we're doing extended field of view, we can see it in the lungs, we can see it in the lymph nodes and the mediastinum. So we can provide not only a comprehensive assessment of cardiac, but also extracardiac assessment. And similar to what I've just shown you with MRI, we have good data to suggest a good prognostic value of cardiac PET. So when you detect it, it has prognostic value. But look at the number of studies, number of patients. In the meta-analysis we just published, you can see it's only 515 patients. So we do need, obviously, a larger number of patients. And in a three-study meta-analysis of abnormal RV uptake, there is also increased event rate. So since we are dealing with patients, not modalities, how do we put it all together? So when I'm reading these studies, this is like literally a consult. So you have to pull up the clinical history, the EKG, you have to pull up the images and look at the images yourself, not only just get the report, because sometimes when looking with other modality, you might get more insight to the images that you see. So what we do is that I'm going to show you mostly the two spectrums. So we have, if you have normal MRI and normal PET, no FTG uptake, then you're done. I mean, no uptake in the ventricle, then you will definitely conclude that there is no evidence of active inflammation. And that's most often the case. If you have normal MRI, the PET should be most often normal. The other end of the spectrum is the patient, very similar to the patient I showed you, where they have significant LGE, and in that same territory, significant FTG uptake. That's kind of as high as could get, and that's a highly probable type of patient. And then in the middle, you have some possible and probable. So the possible is this small area of like LGE, and this is an area that have just some equivalent FTG uptake or no FTG uptake. And this is where it could be an old scar, prior disease. So at that stage, you may not be able to be like really be certain about some of these cases. So there are still some controversies around this disease, at least from an imaging standpoint. Obviously, I'm not going to go into management because that's mostly within EP/heart failure kind of realm. So the first thing is that what about, do we need myocardial biopsy for all patients who have positive MRI and PET? And my answer is always depend. So as I just mentioned, positive LGE or FTG PET doesn't mean sarcoid, and all it means that there is a cardiomyopathy. Obviously, you need to call it sarcoid. You need some tissue diagnosis of these non-ischemic, of these non-caseating granulomas. The problem is that good luck keep going and finding these non-caseating granulomas because it's going to be very difficult sometimes to get these. Sometimes you go by the biopsy of the skin or other diseases. And so to call it sarcoid per se, you probably need to demonstrate these non-caseating granuloma. Otherwise, you're still going to be dealing with probability in there. And that's why there is a biopsy kind of based diagnosis, and then there is the clinical diagnosis. And I'll show you some data how they differentiate. But again, to demonstrate, so our reports come up with a positive for an inflammatory cardiomyopathy because we've had some cases when they went for biopsy, we made diagnosis of alternate disease, rheumatoid arthritis, lupus, IgG4 cardiomyopathies, so all different of myocarditic processes. So what I'm talking about could apply to these too. So obviously the hallmark is cardiac sarcoid, and if you want to call it cardiac sarcoid, then you need to have that. Otherwise, you're dealing with probability. If you have this highly probable pattern, then most likely it's cardiac sarcoid. In the right clinical context, extracardiac involvement, it is highly probable there. But to be definitive, you need to demonstrate that. I'd like to show you this case, actually, just to illustrate how difficult it is to establish that diagnosis. This is a 65-year-old male who actually came to us because of new onset heart failure. He has been having ventricular arrhythmias. a lot of he had a CRT and he had a lot of inappropriate shocks. In fact, he told me one day he got 22 ICD shocks. And then this is the MRI, and you can see, like reading it, you cannot say that this is one cardiomyopathy. This is an end-stage cardiomyopathy with significant late gadolinium enhancement. But with this amount of LGE, all this LGE, this patient went to biopsy and had one time an RV-sided biopsy, and the second one is an EP-guided biopsy, EKG guided biopsy, looking at the voltage signal. And both of them came back negative. Negative in a sense that all they say fibrotic changes. So are we catching it late in the game? Can we not make the diagnosis? But this guy had like no diagnosis, but he was like, and he had no known cardiac sarcoid or any other. He just came with heart failure. But you have a very abnormal MRI, and you cannot tell what is the primary pathology that's causing this abnormal MRI. We did the PET. We can say there is active inflammation. So we said, let's go ahead and put him on therapy. And again, that's another controversy I'll get to. And while on therapy, during COVID, he got called. It was like he was listed for heart transplant, and you got a heart. So he went down, 2 biopsies negative. The explanted heart showed this non-caseating granuloma. 2 biopsies negative, including an LV-guided, LGE-guided, and then on the explant, they found the non-caseating granuloma, and someone who does not have anything known to be sarcoid. So that's the biggest challenge of making the tissue diagnosis. So would I hold the treatment for this patient until I have that? So obviously I cannot be sure. Now I know he's cardiac sarcoid, and it will have implications for him even after the heart transplant. But at this time, it's still early. It's kind of difficult to make that to be certain that this is cardiac sarcoid until we have the granuloma diagnosis. This is another case that one of our fellows published, actually. So again, similar situation. Patient had MRI, some LGE. We did PET, and you can see there's uptake in the septum, some uptake in the lateral wall, and we did call some uptake in the interatrial septum. Someone might argue with me that this may not be very specific, but we'll see how specific it is. So again, looking for tissue diagnosis to come up with someone who does not have known extracardiac sarcoid, they went and did biopsy. They did 8 biopsies of the LV. And then our EP guy, on his way out, you know what? The report says that there is uptake in the interatrial septum. Just put his bioptom and biopsy the interatrial septum. Guess what? This is the pathology report. The LV, all of them, all they say fibrosis, nothing specific. The right atrial septum, what did they say? Non-caseating granulomas. And these are the non-caseating granulomas. So it's kind of like 8 biopsies in the LV were negative, 1 biopsy in the atrium. And again, I'm not here to say do it or not do it, but just to illustrate the challenge that you may get in establishing the diagnosis. So to me, to hold the treatment until I get that, yeah, the labeling, I totally agree. To label it as cardiac sarcoid, you need some sort of non-caseating granuloma. Otherwise, it's going to be more probable and more possible. And this is a paper that just came out last year, actually, which I like it, that in the sense that given that we cannot always be certain about the biopsy and be able to achieve that, so they actually come up with 2 groups. One of them is biopsy, endocardial biopsy positive, so they call it a biopsy group. And that biopsy group actually had biopsy either cardiac or extracardiac. And then they come up with the clinical and imaging feature group. And that one was primarily diagnosed by the combination of cardiac MRI and cardiac PET. And they followed them up. I'm not going to go through the details of this, but they had almost 314 patients that are biopsy proven and 198 that were suspected by clinically. When they looked at outcomes, there's not much difference. These 2 groups, like, it's just that we are unable to illustrate the diagnosis. But it's not that those who we were not able to achieve the biopsy diagnosis are at lower risk. They are as high risk as those of biopsy diagnosis, and that's why probably they should deserve to be treated and followed up like this until we establish the diagnosis in these patients. The other question that I got always asked, like, do we need MRI and PET? Do I need both of them? And in the algorithm, and there have been some meta-analysis here and there doing meta-analysis, which one is more accurate? Shall I do this? Shall I do that? And my approach to this is that we are looking here at two complementary modalities that come in at this different stages of the diagnosis and work algorithm. So I'm not to compare them, to me, it's comparing apples to oranges. So from a diagnosis, you see this meta-analysis, which was published actually in Journal of Nuclear Cardiology, saying that CMR is 94% sensitive and this specific, but PET is less sensitive, more specific. To me, it's like, it's a good exercise, but that doesn't tell me, because MRI, I'm detecting active and inactive disease. So obviously, I'm going to be more sensitive. And in fact, this should be my entry point. With PET, I'm now differentiating active from inactive disease. So all the inactive, you're not going to be able to label them by PET. So that's why. And many of these studies in this meta-analysis actually looked at only FDG. So if you combine it with perfusion imaging, which could be if you have where a perfusion defect is a surrogate of your scar, then you may end up with higher sensitivity. But again, to me, this kind of data is nice to do, but again, like we're comparing apples and oranges. So the start point is MRI, and the follow-up and management is more for CT, by PET. And this is the algorithm that was proposed by the Brigham group some time ago, where you always start with CMR. If it's negative, you probably don't need to go to PET unless something is not fitting in. And sometimes that could be the quality of the MRI or the quality of late gadolinium enhancement. And it is very rare to have a CMR negative, PET positive. And the second one is, if you have a CMR positive, then you need to go to PET, as we saw in all our patients, to identify whether this is active or inactive disease. And often I'm told, like, how often do you see a negative MRI and positive PET? And it is very rare. I looked in our database. We have 2 cases where the MRI was called negative, but going back, and with the bias, obviously, of seeing the PET, now you might say, well, there might be something. And these are usually those patients who come in with an unexplained block, AV block, and this is where MRI might have some difficulty. The interpreter, if you don't have excellent image quality, this is where it's so close to the mitral annulus, and you don't know if am I seeing LGE or it is the mitral annulus that I'm seeing. So there is also some data, and since MRI detects both active and inactive disease, and even the inactive disease, the scarring might result in some arrhythmias. So it looks like CMR, if you have an abnormal CMR, then you're going to have a worse risk compared to those who have an abnormal PET. So the MRI is going to be more predictive because of the type of disease that you are picking up compared to those who have PET abnormal, because you're only now detecting the active inflammation. Another big controversy is, and obviously I've shown you that PET is challenging, and as it goes more in the community, we need to put some quality marks to make sure that when I call an abnormal PET, I want to know that it's truly abnormal and I'm not overcalling disease, because it has a lot of implications. You're putting these patients on immunosuppressive therapies. These patients may become immunocompromised. These patients might have infections, and these drugs are not without side effects. So I want to be sure that there is active inflammation. And how do we do that? And this case was kind of an eye-opening for me. So this is someone who has a perfusion defect, had a positive MRI, and come to PET to see if it's inflamed. And then when I'm looking at this, wow, and this is a patient who told us they followed the diet, because otherwise we would not even have done the study. And when I look at it, there is diffuse FTG uptake. I mean, if this is true active inflammation, then this patient is going to be in VT or bad heart failure. So we said, like, it's just inconclusive. I know you followed the diet. And again, there is no way at that time to verify that, because how would I know if the patient did not follow but just told us that they followed up the diet? I'm just taking their word in there. You explain to the patient that this is like a major decision and we want to be sure, but there is no way at that time to verify that. So we said, okay, why don't you follow the diet even longer? Come to us with a 48-hour preparation. So this patient goes away and then come back to us, and now I have a totally negative study. So between giving them a strong steroid dose, making them immunocompromised versus calling nothing, is a huge difference. And that's why it's very important. So we thought, like, this is a problem that we have. How can we just go ahead and have a little bit more of an objective way? Otherwise, we're at the mercy of what we are being told. So when the patient come to our lab, we started collecting blood on them and sending it to the lab. Some of it we stored. And we started to do beta-hydroxybutyrate, which is like a marker of how long they fasted and how much ketosis they have. And we just kept it blinded initially. And then when we went back and interpreted, what we found is that if we have all our cases that well suppressed, so we were happy with that, a beta-hydroxybutyrate of 0.4, all of them had a beta-hydroxy of 0.4 and higher. And those cases who had like poor preparation, most of them, or 90% of them, had a beta-hydroxy of 0.2 or less. And then in the middle is more of a gray zone, depend where you want to draw your number. So we said, maybe we have found something. So we've adopted it in our lab. Now, whenever for inpatients, we don't do it unless their beta-hydroxy is above 0.4. Still a 2-hour turnaround from the lab. So if you have a workflow, obviously, it's like if you have a patient that's coming in, you don't want to have them wait. So at least it's available for us at the time of interpretation. And then when I interpret it, I know that this is good or bad. So if I see good suppression, then I probably don't need it. But if I don't see good suppression, I see some uptake that's wishy-washy and I'm not too happy with, then I'll just go ahead and look at the beta-hydroxy. And then if the beta-hydroxy is low, then we just go ahead and bring the patient back and emphasize to them that this has been a non-diagnostic study. So we actually adopted it, and since then we had, like, on the inpatient side, no non-diagnostic studies. And so this is something we just published back in December, but a couple of groups also reported this. The University of Michigan have almost similar threshold of 0.36. University of, I think UPenn had a group, had studied this in 20 patients, but they were not sarcoid patients. They were healthy volunteers, and they found a 0.56. So we're kind of all of us hovering around that same number. So I think it's pretty reassuring that if you have that number, now we have an objective way to see, well, there might be something there, and we are up to something. And finally, how do we assess response to therapy? Because cardiac PET is primarily to look for inflammation. This patient in our lab will come have one MRI, but they will have multiple PETs across the spectrum of disease. Because once you demonstrated LGE most likely is not going to go away, but PET is going to wax and wane over time. And this is the same patient I showed you earlier. And when we put them on therapy, their LV did not improve, but you can look at the right atrium. It's significant improvement. And this patient stopped having inappropriate arrhythmias and shocks. So how do we look for that? This is one case that I like because we had a baseline MRI. There's clearly late gadolinium enhancement, clearly positive FDG uptake, although the scar, and this patient had VT and sudden cardiac death, and he had eventually a biopsy-proven cardiac sarcoid. This patient actually, we put them on therapy, and on therapy, you can see that there is significant improvement. So pre-therapy, there was significant FDG uptake. Now there is no FDG uptake. It's all blood pool. But what happened also, you can see that this is FTG uptake, and now it's all gone. But this patient, I like to show it because he had a pre and post MRI. And what you see, the post MRI is actually done with the device. So some of this is the device artifact. But you can see the late gadolinium enhancement didn't go away. So the one in the inferior wall, the RV, all of that remained there. So it's kind of like there is potentially no point in repeating the MRI unless you have another reason to do it. But this patient, they wanted to look at the LGE because it resolved the whole inflammation resolved, and obviously the LGE did not go away. So we have multiple ways to look at this. So we can look at the volume, or now some software will give you how much percent of the LV is inflamed. We can look at the intensity of inflammation, and we can look at the extent. So you can see here, this patient, all of this is an FTG uptake. This is their standard uptake unit. So it's kind of like a unit that goes from, it will tell you how intense is the FTG uptake. You can see there is significant FTG uptake initially, but on therapy, it's decreased, but it's not completely gone away, and the intensity has gone down from 8.4 to 7. But the volume, or the percent of inflammation, has significantly decreased in this patient. So he's heading in the right way, but we're not finished or done yet. And we can also look at extra cardiac inflammation. So you can see this much in terms of inflammation in the mediastinum before and after. And finally, I just want to say that again, I kind of mentioned it, but I want to emphasize it, not all FTG uptake is sarcoid. We've seen it in multiple diseases, but when you have this very mild FTG uptake, think of other diseases. And now with the beta-hydroxy, if I have a good suppression, but there is mild disease, then I could raise the possibility of other diseases. Some of these may be cardiac amyloid. So we're now learning that cardiac amyloid might have some mild FTG uptake. This is one case from Mayo. We had few cases in our lab where cardiac amyloid might have mild FTG uptake. And this is from Ahmed Masri, where the group showed that actually some hypertrophic cardiomyopathies, arrhythmic cardiomyopathies might have some mild FTG uptake. All of them are mild, patchy, and they are like very low SUVs. So nothing like active inflammation, but it could be related to the pathophysiology of the disease. And also, we look at it for extra cardiac inflammation. This is a patient with Takayasu. You can see the vasculitis, aortitis. There's even narrowing of their carotid origin. And then you can see the active inflammation that we see there. So this is a patient this is their CT, and then when I fuse it, you can see the amount of inflammation. Some of it is, and this is a patient where the aortic wall is 1 centimeter, and following it up, the FTG uptake has decreased on steroids, and the wall thickness have decreased on steroids, so we can detect inflammation even beyond the heart. This is a case that we had an MRI. You have significant pericardial LGE. And this patient had FTG PET for other reasons. You can see the pericardium is lighting up. So acute pericarditis, and many of these patients with lupus and others might have perimyocarditis. So this is another situation, and you can see here the thick pericardium and the FTG uptake in the pericardium. So to conclude here, the main thing is that we have a complementary role across the workup spectrum of cardiac sarcoid. I think we always start with MRI because it raises the clinical suspicion and help establish the diagnosis of cardiac involvement. It depends on how much LGE you see and the pattern. And PET is a tool to identify active inflammation and to follow the response to therapy. So with this, I'm going to stop and happy to take questions.
Reno?
In the case of a normal MRI, how do you distinguish a normal variant uptake in the lateral wall on FTG from myocarditis involving the lateral wall? And then when you mention mild uptake, do you mean uptake that is not present on the maximum intensity projection, or do you have an SUV max that you use?
Okay, so these are very important questions. So the first one is, if it is a normal MRI, it's hard for me really to say that this is myocarditis. I mean, MRI is very sensitive for myocarditis. So if it's one of the areas where you might have a normal uptake is in the basal lateral wall. So it's basal lateral wall uptake without FTG, without late gadolinium enhancement on MRI, I would call it a normal variant. Now I have even beta hydroxybutyrate to help me. So I've seen that since we are doing most often those patients that are well prepped, I'm seeing less and less of that lateral wall. If I see lateral wall uptake with late gadolinium enhancement, then I'm calling it because I know that there is something. So it's not all lateral wall uptake is a normal variant. If there is LGE, and I know that the patient is well prepped, I'm more likely to call it than rather not to call it. For the SUVs, I mean, we relied this mild uptake. First of all, if you have significant uptake, it will suppress the uptake in the left ventricle. So usually if you've seen some of these images that I showed here, like the ventricle is not suppressed. So that kind of the mild uptake. And usually their tissue to background ratio is less than 1.5. So you measure the SUV in the ventricular wall and measure the SUV in the blood pool, and the ratio is usually less than 1.5. And this is what you see here. I mean, you can see none of them are like well suppressed in there. Again, FTG uptake, late gadolinium enhancement are not specific for a disease. All these inflammatory cardiomyopathies can give you some of that.
Scott?
Thank you very much for a nice talk. How do you know that the reduction in FDG with treatment represents a positive response versus burned out?
Well, it could be burned out because sometimes, like when we do this, we see the scar burden goes up. So it could be burned out, but usually it's like even in the case I showed you initially where there is so much LGE, but then there was kind of like still some intense. So it's not going to completely burn out in terms of like it will go away completely. Otherwise, it becomes like more aneurysmal or transmural scar. So usually what we see is that so when we're reporting FTG, we can have like an area which is purely inflamed, an area with some mixed kind of scar and this. And what we see usually once you start to have less inflammation, the kind of the scar burden tend to go up a little bit because some of what you called initially as inflammation is a mixture of inflammation and scar. So yeah, some of it might increase the scar, and sometimes I get calls, how come the scar went up? It's not that the scar went up, it's now an area that I called inflamed or predominantly inflamed, had a mixture of inflammation and scar. We took out the inflammation part out, and now we still have to deal with the scar burden.
I think sometimes also clinically they do better. Right? So sometimes the VT goes away, or sometimes the heart block goes away.
So the other thing, I mean, we look also at extra like non-inflammatory markers. We see many times their ejection fraction improve, their LV size reduce. I mean, we had a patient where the LV and diastolic index was 200. 3 months later, the inflammation didn't go away completely, but it reduced, and his ventricular volume almost halved. So a balloon LV, it became much less. So something also to keep in mind. And we repeated the MRI and kind of confirmed these findings. So it's very important to keep that in mind too.
David?
Yeah, just a couple questions. I'm curious of the patient that they say they follow their diet, what percentage still has non-suppressed beta hydroxybutyrate?
So we had about 20% of them. So again, that's why now there is kind of a move to try to move a little bit longer from 24 to 48 hours. And sometimes some patients may require 72 hours. So again, I cannot tell you why they're not being suppressed, but this is something that is very important to keep in mind. Each patient is different. Maybe some of them are on steroids, so the steroid patients may require longer or not. Who are the patients that are not getting suppressed on 24-hour diet. So that's kind of like, obviously there is variability among patients, diabetics, insulin resistance, all these kind of variables there.
And another is that of the scan that's ordered specifically looking for cardiac sarcoid, it's actually not unusual. We see relatively low SUV uptake with corresponding MRI changes in terms of delay enhancement. How do you navigate that?
Yeah, so I mean, first of all, it's kind of, again, a struggle if you don't know if this is poor suppression or no poor suppression. So first of all, you need to confirm that the patient is well suppressed. So once you are comfortable that this is poor suppressed and the tissue to background ratio is above 1.5, then there is probably some residual inflammation. And most of these we're doing serial studies, so it's important to look what was it before. And some of these, like I see that SUVs was 6 or 7, and now they're down to 3. So it's still not completely gone. So I don't use like a very rigid cutoff of 1.5 to call it or not to call it. So for example, we had a patient where their tissue to background ratio was 2.5, very hot SUVs, and then they came back later and now it's 1.4. So there is still some uptake, I can see it, but it's not completely gone. So it's very important to keep both in mind when you are looking at this. So it's kind of coming down, but hasn't completely resolved. And some of these patients actually stop therapy and then they come to you back and it's flaring up. So it is very important to also have a direct communication with the treating heart failure or whoever is managing these to kind of up and down titrate their immunosuppression based on what they have.
Quick question. What change in SUV are you confident represents a real change? What's the variability of that measurement?
So, okay, so that SUV is very important. First of all, it's very much technically, you have to make sure that it's done technically right. So it is the same dose, same time weight, same machine. So if you have two machines, one of them is digital, non-digital. So digital SUVs are different. So if everything is the same, so that's something. I mean, the variability, obviously, so now we've gone from a simple ROI where it could change, we go to a volume assessment. So within 10-20%, I mean, that is something that I would be concerned about. But again, I'm not going just for that like simple ROI that I can move it and change. I think the whole volume of the left ventricle and the softwares that are available will give you that impression, will give you that tool to assess the entire ventricle and see each area like I showed you here. And yeah, so you can see that it's not only the area, it will tell you on a polar map where is it and what's the SUV max within that area. So I usually not just go by SUV, I go by the volume. I go by the entire percent or volume of the uptake. I go by the left ventricle. And we're trying to understand what is it that means an improvement? Because this is a question that always comes to us. Do we need to wait until complete resolution of inflammation until we start to wean down steroids? Because patients want to wean down steroids yesterday, not even today. And they're always putting a lot of pressure on the heart failure doctor. Can you stop my prednisone because I'm getting this, getting that? So that's something to also keep in mind while doing this because it's very important to look at the entire picture, not just base your decision on a number. The area or the volume or percent of inflammation, the SUV max, SUV mean, reduction in LV ejection fraction or improvement, reduction in LV and diastolic volume and everything else.
I have one question for you, Mouaz. Talking about how difficult it is technically to achieve good image quality and quality control. Are there any developments into tracers or different methods that could be a better methodology for?
There are. They're not going to be available clinically in the coming, I would say, 2 to 3 years. So we're stuck with FDG for some time. People have tried some antigens to image white blood cells, and endocarditis, they tried to image bacteria. So there are something, but they are still very early on, and I'm not aware of anything that I can tell you. Next year, I'll come back and tell you, now we found a better tracer that you just inject and image. So we're stuck with FTG for some time.
Wonderful. Well, if there are no more questions, thank you again so much for visiting us today and for everyone for attending. Thank you.